Alright, so this is the first lecture of Unit 6, Systemic Disorders. And in this unit, we took many of the high-yield diseases that you could see on your class exams or on the board exams, and we either grouped them by common biochemical principles and their pathophysiology, or by organ system. So in this first lecture here, we're going to start off with lysosomal storage diseases and mucopolysaccharidosis. So overview of these diseases, they result from a deficiency of lysosomal enzymes. And really what happens when you don't have lysosomal enzymes, you have cellular products that build up within the lysosome. So if you remember from our cellular biology unit, Unit 2, the lysosome is a membrane-bound organelle that contains hydrolytic enzymes. And so the lysosome is essentially like the garbage disposal of the cell, or the cleanup crew of the cell. And so you have all of this cellular debris or cellular garbage, and then these hydrolytic enzymes will break this all down into much more manageable breakdown products. The problem is if you don't have these hydrolytic enzymes, either they're non-functional, or as you'll see in the next disease, they don't get there to the lysosome. These cellular products cannot be degraded by the lysosomes. And this has severe systemic clinical presentations that really come in two forms: sphingolipidoses and mucopolysaccharidosis. So the first disease we'll talk about is eye cell disease, also known as inclusion cell disease, which is caused by a mutation that results in a defective N-acetyl-glucosamyl 1-phosphotransferase, which is an enzyme in the Golgi apparatus. And so if you recall, let's come down here, draw the cell out, and so you have the lysosome out here. And so what this enzyme does is that it works in the Golgi to catalyze the addition of phosphate to mannose residues. So let's draw out the Golgi here, and if you remember, it kind of has a pancake stack look appearance to it. And it really is responsible for processing newly synthesized enzymes and proteins. So you remember you have hydrolytic enzymes, so we'll abbreviate that HE, and they get phosphorylated in the Golgi by this enzyme. And so what that enables them is, so you have them sent out in vesicles like this. And so you have the hydrolytic enzymes like this, and they're phosphorylated. And it almost serves like an address on a package that you would send to someone. And so what this phosphate does is it helps target the vesicle to the lysosome so that the lysosome can receive these hydrolytic enzymes that can break down this cellular debris or cellular garbage that they pick up. The problem is if you don't have this phosphorylation occurring, what happens is that then the vesicles can't be targeted to the lysosome, and instead of going towards the lysosome, they get exported to the cellular surface. So the vesicle fuses with the cell membrane and releases these hydrolytic enzymes into the bloodstream. So two problems with that. One, the hydrolytic enzymes don't get to the lysosome, and so as a result of that, the lysosomes can't break down this cellular debris, and so then you have buildup of cellular debris, and it forms intracellular inclusions, which really wreak havoc on the cells. The other thing, as far as diagnostically, so you release these hydrolytic enzymes into the blood, that doesn't really cause any problems because these enzymes get neutralized at the neutral pH of the blood. What happens though is you see increased levels of these in the serum. And so that's how you diagnose this disorder, by seeing increased levels of lysosomal enzymes in the blood. And some examples of lysosomal enzymes are protease, sulfatase, lipase. And so on an exam, they may, give you some of the clinical presentation, and they'll give you some lab values, and they may not say lysosomal enzymes. They may list, protease or sulfatase or both. And they'll give you kind of the normal range in parentheses over here, and then it'll, have a number here that's higher than the range for both of these, and then you're supposed to deduce that the serum levels of hydrolytic enzymes or lysosomal enzymes are increased, and so that's helped to tip you off that it's eye cell disease. Clinically, these patients demonstrate failure to thrive very early. They also exhibit developmental delay. And then other notable features are a clouded cornea in the eyes, coarse facial features, joint problems, arthralgia, and then unfortunately early death. And these patients are really susceptible to recurrent infections, recurrent respiratory infections, and congestive heart failure. And these really are the two main causes of death in these patients. And so as far as treatment goes, unfortunately, there's no cure, and so you really just have to manage the symptoms as they come. So mucopolysaccharidosis, this is a group of disorders that involves a buildup of mucopolysaccharides, which are also known as glycosaminoglycans or GAGs. And these are long polysaccharide chains that contain amino sugars, which is why they have this name, glycosaminoglycans. And so you see a buildup of these in these disorders, in this group of disorders. And the two really high yield ones that we'll focus on are Hurler syndrome and Hunter syndrome. So you have the extracellular matrix, just to give you a very basic overview of the basic pathophysiology in these disorders so it's easier to remember them. You have the extracellular matrix. It's composed of proteins, carbohydrates, proteoglycans, GAGs, and so forth. So what you need to do is you need to essentially recycle these. You need to break them down and then replace them with new ones. So break them down and replace them. So in these disorders, you have enzymes that are deficient that are responsible for breaking down these components, specifically GAGs or mucopolysaccharides. And so you don't have this. And so what you have as a result of this is then you have a buildup of GAGs. And this buildup of GAGs causes damage and inflammation, which impacts the structure of tissues, the structure of cells, and then as a result of that, the function of tissues and cells. And so that is responsible for the clinical manifestations seen in both of these disorders. So Hurler syndrome, this is due to a deficiency of an enzyme known as alpha-L iduronidase, which is responsible for helping break down heparan sulfate and dermatan sulfate. So since you have a deficiency of this enzyme, you have a buildup of heparan sulfate and dermatan sulfate. And so this causes chronic damage and inflammation and impacts certain tissues. The inheritance for this is autosomal recessive, so they need 2 copies of the recessive allele. Clinical features, this particularly impacts the nervous system, so you're going to see both neurological features as well as cognitive and behavioral problems. So you see retardation, growth delay, delay in developmental milestones. It also affects the eye. You see buildup of these molecules in the eye, so you see corneal clouding. You also see can build up in other organs such as the liver and the spleen, so you can see hepatosplenomegalia. The other thing is you see coarse facial features because buildup of these molecules particularly affects the structure of the musculoskeletal system. It affects cartilage, bones, muscles, tendons, and so it can really affect the development of the musculoskeletal system. And the face is composed of many different bones, and so if you affect the development of the facial bones, you're going to develop these coarse facial features. Now, you may notice that some of these features are very similar to eye cell disease, which we described previously. And so really the way you determine them is by lab test. So in the case of Hurler syndrome, you would do a urine sample that would demonstrate mucopolysaccharides in excess versus in eye cell disease. As we talked about, remember that's because you're not getting these hydrolytic enzymes or lysosomal enzymes to the lysosomes. Instead, they're getting exported into the extracellular space and into the bloodstream. So you're going to see increased serum levels of lysosomal enzymes. So that's how you can distinguish these two diseases apart. The other way you can definitively diagnose this disease is through genetic testing for the exact mutation. So Hunter syndrome, very similar disease to Hurler syndrome, deficiency of a different enzyme, iduronate sulfatase, which is also responsible for helping break down heparan sulfate and dermatan sulfate. So just like in Hurler syndrome, you're going to see an accumulation of heparan sulfate and dermatan sulfate. A couple major differences though. Inheritance, this is X-linked recessive versus Hurler syndrome is autosomal recessive. Clinical features, very similar, but you could almost think of this as a milder version of Hurler syndrome. So you're definitely going to see many of the same neurocognitive disabilities, so retardation, growth delay, delay in developmental milestones, but to a milder degree compared to Hurler syndrome. That also impacts the life expectancy. So in Hurler syndrome, these patients often die before the age of 10. Versus Hunter syndrome, These patients can live in their 20s and 30s in some cases, and even in some cases, they can also have a fuller life expectancy. These patients demonstrate aggressive behavior. They have a lot of behavioral problems that often mimic disorders such as ADHD, autism, and severe levels of anxiety. And so you see, components of these disorders manifested in patients with Hunter syndrome. You also see pink pearly skin lesions over the scapula. That's another unique feature to Hunter syndrome. You don't see this in Hurler syndrome. You also do not see any corneal clouding in Hunter syndrome, whereas you do in Hurler syndrome. And then the other thing I'll mention is, just like in Hurler syndrome, you also will see coarse facial features. Because again, buildup of these molecules particularly affects the musculoskeletal system. So it impacts bone development and bone function, and then also, muscle and tendon structure and function. So sphingolipidosis, this is a group of disorders that involves the breakdown of sphingolipids, which is a special class of lipids that are particularly involved in cell membrane function and also in cell signaling, among other functions. And this diagram here, it's in your book. It shows the breakdown pathway of a variety of sphingolipids down to this final breakdown product of ceramide. And as you can see in blue here, we have the enzymes that catalyze each of these reactions. And then these numbers in these circles correspond to the specific disease in which this enzyme is deficient. And so it's a nice diagram because it shows you both the breakdown and then also the clinical correlate here. So this group of diseases is very commonly found on biochemistry exams. It's also very commonly seen on your board exams. I can almost guarantee you probably will see one of these on your actual exam. And so it's important to learn these. These can be difficult because there's a lot of overlap and unfortunately a lot of memorization. So we'll try to do our best to really show you the distinguishing features. One thing to keep in mind is that a particular population of people that these are commonly found in is the Ashkenazi Jewish population. So definitely keep that in mind because that can come up on tests as well. So first, Crab disease. This is a deficiency of galactocerebrosidase, which is this enzyme down here that catalyzes the conversion of galactocerebroside into ceramide. And so you see a buildup of galactocerebroside and then sulfatides, which includes psychosine. So both of these will accumulate. The inheritance here is an autosomal recessive. And then as a result of these products accumulating, they actually interfere with myelin production and myelination of neurons. And so as a result of that, you see demyelination. And since myelin is so critical for neuron function, as a result of that, you see progressive neurodegeneration. And this is seen very early on. Almost the vast majority, probably 90% or more of these patients, you see severe neurodegeneration and neurocognitive defects really from the time of birth. And really the life expectancy is very short for these patients, unfortunately. It's about 1 to 2 years. And so as far as clinical features go, you see retardation, growth delay, delay in developmental milestones, peripheral neuropathy, you can see muscle weakness, optic degeneration, and then presence of gobloid cells. This is a pathology finding on histopathology, so you can see this as well. And so the takeaway from this disease that can help you distinguish it is that it's really primarily the nervous system that gets impacted here. Some of the other diseases definitely also impact the nervous system, but they can impact other organ systems as well. This is mainly just the nervous system and potentially some muscle weakness as well as a result of that. So metachromatic leukodystrophy, this is a result of deficiency in aryl sulfatase A, which is this enzyme found right here, which converts certain sulfatides into galactocerebroside. And this is the enzyme just proximal to galactocerebrosidase, which is the enzyme involved in Crab disease, which we just talked about. And so as a result of this, cerebroside sulfate accumulates. This is an autosomal recessive inheritance. And this disease particularly affects myelin formation, much like some of the other diseases as well. But this disease really affects the central and peripheral nervous system. So decreased myelin production. And as a result of that, you see severe neurodegeneration. It affects both the central and peripheral nervous system. You see demyelination. Ataxia is a common symptom. The other thing, there's 3 forms of this, and really the only reason that these would be important to pay attention to is they dictate both the major symptoms and then also they can indicate the life expectancy. So the infantile form, the juvenile form, and the adult form. So these correspond to when they manifest in life. So infantile is obviously during infancy. This is very severe. You see muscle weakness that really progresses to complete paralysis. You see vision issues that really progress to blindness. And really the life expectancy of this is about 5 years of age. So very early childhood. Juvenile, you see this more manifest during later childhood, junior high or high school age, adolescence. This one you see more of cognitive and learning issues, problems with memory. The life expectancy of this is much more variable. Could be during adolescence, could be severely limited. Some patients also live for decades. It just depends. The adult form manifests more like a psychiatric disorder. And then it also manifests with memory problems as well, that only get worse and progress to the point of severe dementia. The life expectancy in this is also variable. And unfortunately, there's no real good treatment for this disease at the current time. So Fabry disease, this is due to a deficiency of alpha galactosidase A. You can see that here. And so you see a buildup of ceramide trihexoside as a result of that. This disease is unique as far as its inheritance go because it's X-linked recessive. All of the other lysosomal storage diseases that we're going to be talking about in this lecture are autosomal recessive. And then as far as clinical features go, this has severe manifestations in the kidneys, in the heart, and then in the peripheral nervous system. So you see a big sign of this is actually chronic pain. And so they'll have neuropathy, paresthesias. They have anhidrosis, which is deinnervation of the sweat glands, so they cannot sweat. Peripheral neuropathy, which again, chronic pain. They have burning sensation in the legs, and again, contributing to their chronic pain. And then they have these skin lesions called angiokeratomas, which are these red, purple colored skin defects. They're also at increased risk for developing strokes. And then as far as the renal deficits go, they often develop end-stage renal disease, which clinically can manifest as proteinuria. And then as a result of that, many of these patients have to go on dialysis or even receive kidney transplants. As far as cardiac disorders, these patients often develop cardiomyopathy. You can also have buildup of these sphingolipids within the heart valves, so you can have heart valve pathology. And then you can also see cardiac rhythm abnormalities, so arrhythmias. Now, as far as treatment go, this is actually a disease where there's an enzyme replacement therapy available. Now, unfortunately, this isn't a cure, but it really helps slow down the progression of the disease. And as far as the life expectancy goes for these patients, it's actually much longer than some of the other lysosomal storage diseases. So in males, it's about average age of 50s, in the 50s, and then females can live into their 70s. And many of these patients that live longer into the later decades of life have received a kidney transplant. So Gaucher disease, this is due to a deficiency of the enzyme glucocerebrosidase. So if we come down to our diagram here, this is shown here, which is responsible for converting glucocerebroside into ceramide. So you're going to see a buildup of glucocerebroside because you're unable to break it down. The inheritance for this disorder is autosomal recessive. And what's sort of unique about this particular disease is that you have macrophages that'll come in to essentially clear out this accumulation. The problem is they're not able to break it down either. So you have accumulation of these glucocerebrosides within macrophages, and that turns them into what's called Gaucher cells, which are unique for this disease. And on histology, what you'll see is these macrophages filled with lipids, like we said, and they look like crumpled paper on the histology slide, and they accumulate in the following areas: the bone marrow, the spleen, and the liver, and this translates into some of the clinical findings we see in this disorder. So these patients very often develop bone pain, bone malformations, aseptic necrosis. They're prone to fractures, osteoporosis. On x-ray, what you can see is what's called an Erlenmeyer flask sign in the distal femur. So the distal femur normally looks like this. Where it widens out here just to form the knee with the tibia. However, an Erlenmeyer flask sign or Erlenmeyer sign is when you see widening of the metaphysis. So you see it widen much sooner like this. And the idea is that it's named as such because it's thought to look like an Erlenmeyer flask from the chemistry lab, which, if you recall, sort of looks like this. So that's where it gets the name from. So you can see this in these patients sometimes. As a result of accumulating in the bone marrow, you can also see depletion of a number of cell lines, which is called pancytopenia. So you can see decrease of red blood cells, because those develop in the bone marrow, decreased leukocytes, or immune cells, because those originate in the bone marrow, decreased neutrophils, and then decreased platelets. So these patients are at risk for anemia, leukopenia, developing infections, decreased platelets, so they're at risk for bleeding. They also have accumulation in the spleen and in the liver, as we said here, and so you can see hepatosplenomegaly in these patients as well. So Tay-Sachs disease, this is due to a deficiency of hexoaminidase A, which is the enzyme found down here, and is responsible for converting GM2 ganglioside into GM3 ganglioside. So as a result of that, you're going to have GM2 ganglioside accumulate, so you're going to have increased sphingolipids in the nervous system, much like many of these other disorders. And so it's going to really wreak havoc on the nervous system especially. Inheritance-wise, it's autosomal recessive. And then on cellular analysis, you'll see onion skin lysosomes. That's kind of a buzzword to pay attention to. And unfortunately, this disease really causes severe neurodegeneration very early in life. It actually manifests often by about 6 months of age. And so when it does manifest clinically, you'll see a severe decline in the child in terms of psychomotor retardation, muscle weakness, severe neurodegeneration, like we mentioned, mental retardation, developmental delay. You'll see patients even progress to the point of where they'll have severe total paralysis. On eye exam, which is not totally unique to Tay-Sachs, but you can definitely see it, and it's a high yield thing that shows up on exams a lot, is a cherry red macule on fundoscopic exam of the eye. And so this is what it looks like here. It's this bright red circular structure like this, kind of looks like a cherry. Patients can develop blindness. They can have vision problems that progress to the point of being totally blind. And unfortunately, this disease is usually fatal within the first few years of life, often early death by the age of 2. So this disease has a very similar presentation to Niemann-Pick, which we'll talk about on the next slide. And the way you can differentiate it is Tay-Sachs does not have hepatosplenomegaly versus Niemann-Pick, which does. So the last disease we'll talk about is Niemann-Pick. This is due to a deficiency of the enzyme sphingomyelinase, which, as you come down to the diagram here, is found here. So you have a deficiency of that, which would have converted sphingomyelin into ceramide. So logically, you have a buildup of sphingomyelin, which is a key component of cell membranes. You see this disease particularly affect the brain, the liver, and the spleen, because you see significant buildup of sphingomyelin in those structures. Inheritance is autosomal recessive. On histology analysis, you can see the presence of lipid-laden macrophages or foam cells. Clinical features, again, you're going to have severe neurodegeneration, so mental retardation, microcephaly, and then nervous, really even central and peripheral nervous system degeneration. And so you can see ataxia, which is difficulty balance and difficulty walking, dysarthria, which is difficulty with speech. You can see dysphagia, which is difficulty swallowing. You can also see dystonia, which is changes in muscle tone, and then even seizures can happen as well. So very debilitating disease. Like Tay-Sachs disease, you see these symptoms manifest very early in life during infancy and young childhood. Like Tay-Sachs, you also see a cherry red macule on fundoscopic exam. Difference between Tay-Sachs and Niemann-Pick is with Niemann-Pick, you do see hepatosplenomegaly, so enlargement of the liver and the spleen. And unfortunately, this disease as well has a terrible prognosis where you see early death, usually by the age of 2 years old. And then you can also see zebra inclusion bodies as well on cellular analysis. All right, so that closes out our discussion of lysosomal storage diseases and mucopolysaccaridosis.